So we asked the question of, does neighborhood disadvantage increase risk of repeat observation hospitalization after an index hospital stay? And what we found that after an index hospital stay, living in a disadvantaged neighborhood in the most 15% disadvantaged neighborhoods across the country conferred an increased risk of repeat observation of about 43%. After we adjusted for factors such as race, disability, Medicaid status, and chronic comorbidities, that risk remained at a rate of about 13%. My name is Ann Sheehy, and I'm an associate professor at the University of Wisconsin and division head of hospital medicine. And our manuscript called 30-Day Reobservation, Chronic Reobservation, and Neighborhood Disadvantage will be published in the Mayo Clinic Proceedings. To put that 13% into context, that is equivalent to chronic comorbidities such as congestive heart failure, peripheral vascular disease, and it is a greater risk than chronic pulmonary disease. So it shows that where you live and the environment that you live in can increase your risk of repeat observation stays. We also found that what we coined a term called chronic reobservation, and that is there was a small number of patients that had more than one observation stay within 30 days after an index observation hospitalization. And we found that as patients had more and more observation stays in that 30-day period, the more disadvantaged they were. And this is really important because of how Medicare covers observation stays, in that the more often you have observation stays, the more likely it is that you're going to pay more out of pocket. So it's our most vulnerable and most disadvantaged Medicare beneficiaries that may have to pay more for their medical care because their hospitalizations are classified as observation. Patients can be hospitalized under observation or under inpatient. And so observation hospitalizations are increasing across the country. And I think most people think of observation as care delivered in a unit adjacent to an emergency department for a short period of time. And that does happen. However, we know that there are a lot of emergency hospitals across the country that don't have observation units. And even those that do have observation units deliver observation care on the wards or even in intensive care units. And so because Medicare covers observation stays differently, Medicare beneficiaries may be vulnerable, especially when they have frequent observation stays under what would have been a normal inpatient benefit period. So the Area Deprivation Index, or ADI, is a validated composite ranking of neighborhood factors. There's 17 such factors that are incorporated into the ADI, and they encompass housing, education, transportation, income. And what we did is we looked at ADI, and we looked at the patient's 9-digit zip code, and we geocoded that to their ADI ranking. And the ranking is a 1 to 100 ranking. With the higher the number, the more disadvantaged the patient is. And we compared the least 85% to the most 15% disadvantaged population in this study. And that cut point was based on prior work that looked at 85th percentile versus 15th percentile. So there were two other findings of the study. First, we found that there was geographic variability in index stay, observation stays across the country. So when we think about a federal policy, we hope that it's applied equally across the country, and that wasn't the case in this study. Our study wasn't designed to tease out the factors of why that may be, but certainly raises the question about why observation use varies across the country. Second, and probably most importantly, we found that there was several other factors that conferred increased risk of repeat observation stays. First, having a long index observation stay, one of 3 or more midnights, conferred an increased risk of repeat observation stay after an index observation hospitalization. And second, we found that discharging to a skilled nursing facility after an index observation stay actually was protective against repeat observation. Unfortunately, our most disadvantaged patients were both most vulnerable to have long index observation stays, and they were less likely to be discharged to skilled nursing facilities after their index stay. So this again shows that our most disadvantaged patient population is most vulnerable to the adverse consequences of observation policy. This is also important because of policy implications and the fact that Medicare states that patients generally staying longer than 2 midnights should be considered inpatients. And so having a cohort of patients that stayed 3 or more midnights and still have those stays be classified as observation really raises the question of whether those patients were deprived of their inpatient benefit. And again, our study was not designed to tease out that factor to that degree, but it is an interesting and important point. Second, we know that Medicare covers post-acute skilled nursing facility stays after an index stay of 3 midnights or longer if those midnights are inpatient. So the fact that our patients had 3 midnight observation stays means that those patients would not have had their skilled nursing facility covered if they needed it after their stay. And furthermore, because we know that discharge to a skilled nursing facility after an index stay was protective against reobservation, this again adds to the complexity of this policy, and it again shows it disproportionately impacts our most disadvantaged Medicare beneficiaries. Well, this means that our Medicare beneficiaries that are most likely to have difficulty paying for their hospital coverage may be the most likely to be disadvantaged by these policies. And furthermore, it means our Medicare beneficiaries that are most disadvantaged may be most vulnerable to paying for skilled nursing facility coverage out of pocket. Well, we hope that this study will help prompt policy reform. We know that when Medicare was created in the 1960s, this was at a time when Medicare beneficiaries, the age of Medicare beneficiaries, they were the most likely to be uninsured and the most likely demographic to be living in poverty. So Medicare was designed to help those patients, and we think that our study here shows that Medicare is actually not helping those. It's actually failing that demographic that it was intended to help. So we hope that our findings help prompt policy reform. We also are interested in studying this in the Medicare Advantage population. We're interested in studying hospital-level factors, and we're also interested in studying the interplay of inpatient observation stays and how that impacts our most disadvantaged population.
We hope you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you'll find access to information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.